So you have your atria and you have your ventricles, and when your ventricles contract, that pumps the blood out to your body, right? Right before the ventricles contract, the atria give a little bit of extra blood to the ventricles, and so the ventricles then have more blood and more oxygen to be able to pump to the rest of the body, okay? So the reason it's important to just understand that a little bit is because it correlates to our little rhythm here, our waveform, okay? And so we have the atria. So when you see a P wave, I want you to think atria, or the top chambers of the heart. And then the QRS is the ventricle, right? And then we rest, okay? So with every beat, this is what we should see. We're not going to worry so much about the Q wave or the U wave. As I said, we're going to talk about need to know. And there's a lot of fancy stuff that even I don't know, but I haven't needed it in 25 years. So, you know, unless it becomes some revolutionary thing to monitor for, I'm not going to worry about it. Okay. So the other things that are important, so we have the mechanical part of pumping, and then we have the electrical part that tells the heart what to do. So we have an SA node here. So I think of it as just a cell that's in charge. And it really is like a group of cells that make a node and all that business. But I like to just think of it as there's one cell that's in charge. It sends the electricity to the AV node, and the AV node then sends the electricity around and lets the heart know, okay, it's time to contract, okay? So again, here, this is the SA node right here. It's going to tell the atria what to do, and then this is the AV node that's going to tell the ventricles what to do, and then everybody has to rest and get ready for the next beat. There's also an isoelectric line, so you should be able to draw a line on any of our papers, and all of your beats should come back to it when they're done, right, with their part. So the P wave always starts at the isoelectric line, and that, like, it's kind of like no electricity. And then we have our P, and then it comes back to the isoelectric line. And that's also where you think about measuring. If you're in a rhythm that's maybe a little different and you're trying to figure out where should I measure this, always look to see where does it meet the isoelectric line again, because that will help you figure out where you should measure, okay? And then again here, it leaves the isoelectric line, and then it comes back to the isoelectric line. And then it leaves the isoelectric line during rest, and then it comes back to the isoelectric. Okay, so those are just a few things to note. And then you have like the definitions here on your paper if you want to see what the definitions mean. When they talk about a negative deflection, that just means that your waveform goes down. And if it's a positive deflection, it means it's going up, okay? Okay, so anything that is sinus is coming from the sinoatrial node. And that's why it's called sinus. So anything, any rhythm that has a P for every QRS is going to be sinus something, because it has that P wave, okay? Anything normal is going to mean all of your parameters are normal. You have a P for every QRS. All of your measurements are normal, and we'll talk about the measurements in a little bit, but all of your measurements in seconds, they're all within a normal range. And that's really it. That makes something normal. So it can be sinus rhythm or sinus tach without being normal, because something is outside of those normal measurement parameters, okay? So normally we have the SA node fire, then the AB node receives the impulse and then sends it around. If we have a block, if we have an AV block, it means that there's a problem with the SA node getting to the AV node. There's a problem there. If it's a bundle branch block, then it's down here in the bundle in the ventricles, okay? And then if it's just ventricular, we call it idioventricular. Anything ideo means there's no cause, there's no reason that we can identify. So we just call it ideo. Okay. All right, so our paper. So our paper is in seconds, right? Our smallest box is 0.04 seconds. And our big boxes that have like the bold lines is 0.2. And then we have little hash marks on the paper. These little hash marks are 3 seconds on the paper. Okay, so and we want to measure everything in at least 6-second increments. So if you were to print out a strip and measure it and analyze it, you'd want at least 6 seconds, especially if it's in irregular rhythm, so that you have enough time to really see what it's doing. Okay, so if you remember nothing else, just remember 0.04 and then multiply however many boxes you have by 0.04 and you'll get there. Okay, all right, so that's our measurement. And then yeah, and then I already talked about the other stuff. Okay, there's also this method called the 300 method. It's really just to guesstimate rate. It's just an easy way to be able to glance at the monitor, especially if there's an emergency, and basically see how fast or how slow the heart might be going without having to count. Now we have monitors with numbers, so generally that's not as big of an issue unless it's counting like the T waves too many times or it's double counting or something like that. So this is kind of a nice-ish to know, maybe not a need to know, but what you do is you'd find a QRS on the bold line. The next bold line would be 300 beats per minute. So if I had a QRS here, then my heart rate would be at least 300 beats per minute, which is what VTAC usually does, right? And then the next one would be 150, 100, 75, 60. So this one is between 60 and 75. Okay, so it's probably a normal sinus rhythm. Also, if you have a regular rhythm, then you can just count in a 6-second strip and multiply by 10. And that'll tell you what you got. Okay, so here's just a few that we can kind of guesstimate the rate on. What do we think about this one? These are all 6-second strips. Yeah, so 40, right? We have 4 beats. They appear to be regular, multiply by 10. Yeah, so sinus Brady. What makes it sinus? Right, there's a P for every QRS, so it's a sinus, okay? What about this one? Sinus. Good, sinus Brady. So there's 5, multiplied by 10, you get 50. Okay, so that's just, what else do you see on here other than just rate? Is there any other rhythm that kind of sticks out as something different? Yeah, this is definitely an AFib. So it's irregular, and then you kind of have just these little wiggles in between. You can't really tell what's a P wave or not. What about this one? It looks like a flutter, right? Flutter waves. Now it kind of can go either way because usually a flutter, all the P waves look exactly the same and they're more kind of uniform and you can actually count them in between. But these do look a lot like flutter waves. So maybe it's an AFib trying to go into a flutter or vice versa. But yeah, definitely it looks a little different than this one. Okay, so the R to R interval, as well as the P to P interval, if you have a normal rhythm, they should all march out. So if you took a piece of paper, this is old school, where you find a QRS and you mark a line on the piece of paper, and then you mark another one, you need to have at least 2. And then you just move it along your QRSs, and they should all match up to the lines. So we would say it marches out, okay? And you could do the same thing with P waves. Or you could be fancy and take your calipers and, you know, just spread the calipers apart, leave them at the same distance, and then it should match up to all of your QRSs as you go. And then this is just an illustration to show you this is the QRS, and then these are the P waves. Anyone want to take a guess at what this rhythm is? So third degree, yeah, so there's not a P here. We're randomly dropping QRSs, but the PR interval is different too. So yeah, I think it's a third degree. I think you're right. So the P's march out like the whole time. So there should be, or there might be a P in there. The PR interval that we can see, they're all different. If this was a second degree type 2 where we randomly drop QRSs, then this PR would be the same as this PR, right? Good. So every P wave should be followed by a QRS. You cannot measure a PR interval in AFib because you cannot find a discernible P wave. Sometimes you see one and you're like, oh, that looks like a P wave, but there's no way to like really identify that there's more than just that one, or, you know, what the interval is. Our T wave should be rounded and upright. If it's inverted, there could be some ischemia, there could be an issue. A lot of patients just always have an inverted T wave. So it's more about a change in the rhythm. If their T wave is upright most of the time and now all of a sudden it's a downward deflection, then something has changed, and you know, we may need to alert the physician. Okay, so here's our, these are all AV blocks. We're not going to really talk a lot about bundle branch blocks today. So this is our second degree AV block, Mobitz 1 or Winky-Bach. So I always remember that it's Mobitz 1 or Winky-Bach because you wink with one eye. So that's how I remember that those two go together. And that's where you have the longer PRs and then you drop a QRS. And then the Mobitz 2, you just, all your PRs are the same, but you first drop this actually looks like the Winky-Bach here.
I think
this is first degree, huh? The first degree block is just a prolonged PR. Yeah. This is the Winky-Bach where it gets longer. And it's always this rhythm, or always this pattern. Longer, longer, longer drop. And then the Mobitz 2 is just the random dropping of QRSs, and all the PRs are the same. And then the third degree block, as we already saw, all the P's march out and all the QRSs march out, but they don't do it together. There's no rhyme or reason. Either the patient's had an MI or they have some scar tissue in their heart, and the message from the atria cannot get through. It's like they've closed all the freeway off ramps and there's nowhere to get off, so it can't make it to the ventricle.
And it makes the jungular escape because that first QRS doesn't have that P, right?
Correct. The other thing to note about the QRS is that if it's narrow or normal, so if it's 1 or 1.5 boxes, it's atrial. It's coming from the atria originally. If you have a wide QRS, it's coming from the ventricles. So if you're trying to decide, is it VTAC, is it SVT? Because sometimes someone might have a left bundle branch block where they have a kind of a wide QRS. And then if it gets kind of fast, it can kind of look like VTAC. And so you have to ask yourself, you have to measure, and then you have to look for the P waves sometimes to differentiate between the two. So we'll see examples of those as we go along. So here's your heart block poem. So this I didn't have in your handout, but I can get this to you if you want it. And it is hanging up by the monitor tech desk. So if the R is far from P, then you have a first degree. So all of these PRs are prolonged. Do we care? I don't know. It's something to note. It's something to document. It may or may not be a problem. If it's something the patient chronically has, the doctor's probably going to look at the meds that they're on, their history, and then we're just going to kind of watch it. So it's not like an emergency kind of situation. Although this one is pretty long, right? And then PR gets longer, longer, longer drop, then it's a case of Winky Bach. And so that's the PR here is one measurement. It actually looks pretty normal here. And then it's longer, longer, and then you have no QRS. And all of your Ps and QRSs that you do have march out, okay? If some Rs don't get through, prepare to pace that Movitz 2. So this is where you just randomly drop, and it could be in a pattern or not. You know, it could be very infrequent, or you're dropping QRSs all the time. Now, this could be a problem. If you're talking about cardiac output, then whenever they don't have a QRS, you're not getting any blood flow to the body during that beat because it's not contracting. It's just the atria contracting into the ventricles, and then that's it. And then it starts again. So this could be a problem. And so we're, of course, we're going to check electrolytes and, you know, maybe get a 12 EKG, because we can't diagnose from our monitor strips, but we can look at trends and we can notice changes. And then the nurse can get an order for the 12 EKG. So that may be something you find yourself recommending, you know, something's going on here. You might want to get a 12 EKG to confirm. Okay. And then if the R's and P's don't agree, prepare to pace that third degree. So the third degree is usually really slow and it's not organized. So you're really only, this would be like a heart rate of 30, because the QRSs are the only things that really count as far as blood flow. Okay. People that come in with a third degree heart block, a lot of times they're dig toxic. They've had too much digoxin, which is a drug that slows down the heart and makes your contractions stronger to try to help your an irregular rhythm. It tries to kind of organize it and help it out. Or it could be like a lack of oxygen or something like that. So sometimes this patient will keep in the ICU and just monitor them for a couple of days, and they'll get better because whatever they were doing, they're not doing now. Or we can give them something called Digibind, and it can get rid of that digoxin that they have in their body, and their heart will go back to normal. Or it could get worse, or the doctor's just going to take them for a permanent pacemaker. In the ICU, if they, sometimes they're like this, but their blood pressure's okay. If their blood pressure's okay and they're not like confused or anything, then we'll kind of, there's a little bit of time to decide on a pacemaker or whatever. But if they're not, they're confused, they're not oxygenating well, their vital signs don't look good, then we can put in a transvenous pacemaker, which is like a central line. You can put a wire into the heart and you can pace the heart from the inside. Or we can put the defib pads on the outside and pace from the outside. All of which you would see on the monitor. Okay, so it's important from a monitor check standpoint to know what are we doing about this, and this is really uncomfortable to watch throughout the day or night. It's usually the night that we're watching it, because during the day there's resources and doctors here that could actually put in the pacemaker. The intensivist, depending on the intensivist, they may be willing or able to put in a transvenous at the bedside. But we don't do that as often as we used to. They do that more in the cath lab. So it just kind of depends. And so then it would be important for you to know, hey, we're putting in a transvenous pacemaker, so your rhythm's going to change. You're going to see a paced rhythm. And same thing if they get the permanent pacemaker. Okay. Okay, so here we're looking at where we measure. So the PR interval is from where the P wave leaves the isoelectric line all the way to the Q. It's a PR, but it really should be called a PQ, but we don't. We call it a PR. So this is where you're going to measure your PR, kind of where your QRS starts and your from where your P starts. So this is just a couple of examples of where we measure, and our normal is 0.12 to 0.2. We don't really care if it's too small. We really only care if it's greater than the 0.2. Okay. And then we have a block of some sort. And then we have the QT. We also have a QTC, which it's just a kind of a more personal QT. It's not super important for our purposes of monitoring and all of that. The thing we care about with the QT is if it's too long. And a lot of the drugs that we give, especially in the ICU, can prolong that QT wave. And we care about that because if this gets longer and longer and longer, it can then butt into the next beat. And so the atria kick in and try to do a P wave in the middle of this, or even an R wave in the middle of the T. So it's relaxing and then it gets interrupted and it's told it needs to go, it needs to keep working. And so you could go into a lethal rhythm. Okay, so that's why it's important to just note what the QT is as a baseline and then if it's getting longer. And it's not like it gets longer over an hour or two. It's like it's 4 or 5 now, and then in 12 hours, maybe it's 0.5, and then another 12 hours, it's 0.55. It's kind of like that, usually that kind of lengthening. But it would affect the drugs that the nurse can give. So it's important that the nurse knows what the drugs are that the patient's getting that can cause a long QT, and then to know the QT is getting longer. So now I need to let the doctor know, hey, do you want to change this drug? Because I think it might be affecting the QT interval. Okay, so it is at the Q, beginning of the QRS, all the way to the end of the T when it comes back to the isoelectric line is where we're measuring that. So this is why we care, because here we are, marching along, and then all of a sudden we're in a torsades. Okay. Nobody really talks about the J point. It's just a way to talk about the rhythm. Where the QRS comes back to the isoelectric line is where the ST, where it leaves again, that's where we get our ST. So if this QRS doesn't come back to the isoelectric line before the T wave, then we call it ST elevation. Okay. And here's the picture of an isoelectric line, and you can see the QRS comes back to the line, and then it goes a little, and then the T goes off the line again, right? Here you can see we've got some elevation. It didn't come back, it kept going before it did the T wave. Here we have some depression. Why do we care about depression? Because usually it's like a mirror. If you have elevation, and these are really bad elevations in one lead or one side of the heart, this is the front of the heart on a 12 lead, we have ST depression in the opposite leads a lot of the time. So if you see ST depression, it means they could have ST elevation in another lead. So it definitely means we need a 12 lead EKG. Okay. And when they say it's a tombstone, it's because it looks like a tombstone. Okay. You guys seen that?
That pretty much means the R goes into that tombstone effect, right?
This is, yeah, like this whole thing is the R and the S, like it's all together. You can't really discern. That patient's dying right now. Like we're getting ready to code MI, going to the cath lab. We're going to try to save their life. That's super bad if you see that. Okay. Okay, so I mentioned the QRS, and if it's narrow, it's atrial. If it's wide, then it's ventricular. So this shows you a narrow one. So you're measuring from here to here when it comes back to the isoelectric line, and then here to here. It's pretty wide. Okay. If you have a, let's see. So bundle branch block will make your QRS a little bit wider. And of course, BTAC, we're going to show some examples of lethal rhythms here in a minute. A PVC, premature ventricular contraction, we would expect to be wide because it's in the name, it's ventricular. Supraventricular means above the ventricle. So it's going to be narrow because it's above the ventricle. Okay. And then idioventricular is really bad, and that's really just a few really wide, ugly beats. And then paced is also a little bit wider. We generally pace the ventricles more often than we pace the atria, and at least in the hospital. And we'll see the pacer spike and then the wide QRS because we're pacing the ventricle, and then it contracts, so it's a wider QRS. Then we have some non-arrhythmias. So what do you think is happening in this one? And can you guess what the rhythm is, even though it looks funny? Where are we getting these readings from? Where do these waveforms come from? Like, how do we get them? The nurse puts patches on, right? So we're getting it from these leads that are stuck on the outside of a body. And if you've seen some people breathe, they breathe with their belly, or they're having trouble breathing. And so those EKG leads sometimes are like moving up and down or in funny ways. And that is reflected in this. So this would be called like respiratory artifact or respiratory waveform. So it's not an emergency. You might let the nurse know, hey, it's picking up all the breathing, the funny breathing your patient's doing. One, is that normal for them? And two, maybe you could adjust the patches so that we could get a better reading. You can kind of see there's a P wave here. Hard to tell there. There's a P wave here, a P wave here. They all kind of look the same. It's probably sinus rhythm. These look pretty narrow. So it's not like it looks like they have a bad underlying rhythm. It's just, it looks like there's some breathing involvement. What about this? What is this stuff? And do we care about it? Yeah, it's just artifact. And the only problem with it is I can't tell what's a P wave and what's not. Like in my mind, I'm imagining these kind of are P waves maybe, but how do you really tell? It's just so wiggly, you know? The QRSs are narrow, so I'm not super worried. The rate kind of looks okay. But that's definitely, you know, I would give that a little bit of time to see maybe the patient's just eating or something. And then after 5 or 10 minutes, hey, you know, there's a lot of artifact in your waveform. Maybe they need new patches, or maybe they're really hairy and nobody clipped where the patch goes, because we're supposed to clip and use alcohol wipes to kind of make sure it's clean and dry, and then put the patches on so we get like good contact with the skin. Sometimes there's not time for that, or sometimes the patient is moving a lot, or, you know, those kinds of things. So, and the nurse will tell you, oh, my patient is really squirrely. They're moving all over the bed, and it might just be something that you kind of have to work with. And when you see a good one, you're like, oh, I need that one to measure, you know? So that's just a point of communication, but it's not like it's a bad, like harming the patient. So on our tele boxes, it tells us how to put on our patches so we can follow the pictures, the diagram. This is just an illustration of where the 12 lead chest leads go. So when you're looking at a 12 lead, the V leads are all chest leads, anterior leads. And so I mentioned that you have to, you know, shave. Of course, you don't have to shave their whole chest, just the spots where the patches are going to go. And we're supposed to change them every 24 hours. So that can affect accuracy if you have someone, especially if they're sweaty or drooly or whatever. And then, so here's the mnemonic. So we have white on the right, and then black is opposite white, and then smoke over fire, and then snow over the grass, and then chocolate wins the heart. There's a few different ones. The other one is like poop is in the tummy, and this is like right over the tummy. Whatever works. I like that chocolate wins the heart, but the poop one is probably one I remember more. So there you go. Okay, so if we're off telly, a lot of times it's just one of the leads is off, or they like to flip around and stick to the inside of the gown. And then it's like, no, their leads are on. Well, no, you got to look underneath and you can see that the sticker is stuck to the wrong spot. Here's some really bad artifact and more bad artifact. This, most asystole doesn't look like a exact straight line, but definitely something we have to investigate and look at the patient. Are the leads on or off? And see where we're at. Here's some more artifact, but thankfully it's just little spots. Is this VTAC or is it teeth brushing? Because you can go in and wiggle the lead and it'll make it look like that. And then again, this could be coughing or movement. And then this is another one of those kind of breathing, a little bit of breathing artifact. But without the patient in front of you, we just have to make the phone call. So all the sinus rhythms, they're pretty easy, P for every QRS, and then it's just about the rate. So 1 to 60 or 1 to 59, and then 60 to 99, and then 100 to 150, and then greater than 150 is usually a supraventricular tachycardia. And sometimes you can slow it down if you're not sure if there's P waves. So on the monitor, you can tell it to change the sweep speed, and it'll actually slow it down and stretch it out. And then you can see if there's P waves. So that's kind of a fun thing to do. You go into the settings, I want to say monitor setup, and it's called the sweep speed. And you can just change it and it'll slow it, like puts it in like slow motion. Okay, so the PR, we talked about the PR interval. If it's greater than 0.2, we have an AV block. QRS greater than 0.12, we could have a bundle branch or a bundle, or a ventricular rhythm, any kind of weird beats. So we talked about PVCs, PACs, we'll talk about in a little bit. And then bigeminy, trigeminy, quadrigeminy just refers to where the PVCs are located in a pattern. So if you have every other beat or every second beat is a PVC, you have bigeminy. If it's every third beat, it's trigeminy, etc. Okay. It's not the number in a row. It's where it's placed in the rhythm. And then ST elevation or depression. If you have peaked T waves, which we don't have a picture of here, but when they're really, really pointy, that happens when you have a high potassium, tall tinted T's. So, but it's only as good as the accuracy of the monitor, because you can increase the size of stuff on the monitor, make it look funny, and then is there a prolonged QR? Okay. So these are just the characteristics of a normal sinus rhythm. And then, so Brady, I'm just going to kind of go through these quick, but there's some notes for you there, all the characteristics of sinus Brady. We already talked about how to count it. And then sinus tach is also, it's just fast, but you have all the components of sinus rhythm. And there's all kinds of reasons for that. Sometimes it requires an intervention. Sometimes it's just like today, we had a code gray and that patient's heart rate went up to 160. But once they got them calmed down, heart rate went back to like 115. So it doesn't always require an intervention and you can't always fix it. But if it's greater than 120, it definitely deserves a phone call, especially if it's something new or sustained.
So like with the patients that have patients that have the code gray and the heart rate went to 160, you don't call the nurse because they're busy.
Well, if you didn't hear the code gray, then I would call. Okay. But like we heard the code gray and that matched the room number we were looking at. So yeah, it was like, no, I'm not going to call because I know what they're doing,
But would you like print the strip and then
I don't even know that you have to do all of that.
Okay.
But when in doubt, it doesn't hurt to print it, just in case, you know? Because a code gray could turn into something else. It's a code gray, you print the strip and you wait a minute because you know they're dealing with it. And then now it's an RRT and you're like, oh, okay, here's the strip that I printed as they're, you know, coming down the hall. Because that's why we put the RRT cart right there. So the monitor tech can at least holler, hey, this is what they're doing on the monitor or not doing. So in that instance, you know, that would be a good thing. But worst case, you just shred it, you know? Yeah. It's a good question. Okay, so here's some more examples. So let's do a couple. Okay, so what about this first one? What do we think is going on there? That looks normal. Yeah, sinus rhythm. Okay, what about the next one? These are all normal, yeah, or just at least sinus. So this one, and it's hard to tell, you know, from a distance. I really think if you're measuring, you either need to freeze the waveform or print it out. So whenever I'm having a problem, like I'm looking at my patient on the monitor, and of course it's always going across. Usually it's pretty, after practice, it's like, oh, I know what that is just by looking at it. Sometimes it's like, I'm not sure. I'm gonna print it or freeze it on the screen and measure it that way, because sometimes it's hard to tell when it's going across. So here we have a little bit of a prolonged PR. And then maybe a bundle, it looks like it's 2 boxes, maybe 3, that may be a little bit of a stretch to be a bundle. But the PR is prolonged here. What about this one? Yeah, sinus Brady. So 1, 2, 3, 4, 5 times 10 is 50. Okay, how about this one? We don't like the way it looks. QRLS looks funny, huh? And it's kind of small. The monitor in this case might read something wrong because it's counting all of these like the same, because they're all kind of the same height. You might have to go in and change the size of the QRS. So sinus Brady with a bundle branch block because of the prolonged QRS. How about this one? Sinus tack. And this one you really have to look at because the T kind of looks like the P. You know, they kind of go together. Okay, what about the next one? It's Brady. What about the QT here? Maybe it's prolonged, right? It's a couple of big boxes. It's hard, you know, you'd have to measure that one. So sinus Brady. But this one? Yeah, the T is upside down. Definitely, we have an inverted T. There might be some depression. So sinus rhythm, bundle branch block, because these are a little bit wide. Again, I would have to like measure to be sure. T wave inversion. So our T waves are upside down, and maybe some sinus, ST depression, because it does not come back, right? Okay, good. And what about the last one? It's kind of hard to tell. Maybe. I mean, it looks like it comes back. Okay. And those are in your packet. So you're well, you know, you can play with them and see. The other thing I want to point out is the shape of the waveform. If it comes from the same place, it's the same shape. So if I have a P wave and it always looks like it's the same shape, then it's that impulse is coming from the same spot in the atria. Why that's important, if you have PVCs or PACs, the shape matters, right? So I just kind of want to point that out as we move along. So a few more examples. So what about this one here? That first one. What looks funny there? Yeah, the T wave is really pointy and upside down for sure. So sinus rhythm with T wave inversion. What about this one? It's a little more obvious. Yeah, ST depression for sure. And it's pretty significant. So what about this one? ST elevation, yeah. And this artifact. How about up here? Yeah, and what do we think about this? The PR? Yeah, it's kind of, it's long, right? It looks long. So I would add a first degree block, and then I'd have to measure, but yeah, it looks like the QRS is also a little bit long. What about this? Say that again? Yeah, sinus tach. And what do we see here? What is this thing? It's that respiratory breathing, right? The breathing pattern a little bit. Okay, and then second to last. And the last one. Yeah, it's just sinus. Good. Okay, so then we have atrial and we have ventricular rhythms. So the atrial rhythms are pretty much AFib or A flutter. Those are kind of the main things. How do we differentiate AFib and A flutter from some of the ventricular rhythms? The QRS. QRS is narrow in these because it's coming from the atria. Okay, so if you're seeing something funny and irregular and you're trying to decide, you know, what am I looking at? Because sometimes you don't see any P's, sometimes you see a bunch of P's. Like it's kind of hard sometimes to tell that QRS, if it's narrow, you know it's something atrial. Okay, so this is just an example of how the electricity moves in a normal heart. And then this is the AFib. So between AFib and A flutter, we're going to treat them pretty much the same meds, the same interventions. If it's a new AFib, the patient's been trucking along at sinus rhythm or sinus tach, and all of a sudden you realize, oh, now it's irregular. It wasn't irregular before. And it's hard to tell sometimes when they're tachy the whole time, but now they're AFib and they're tachy. And it's like, did that change? And so you look and you're like, yeah, it's irregular now. That's an important finding because now the patient can develop blood clots in the atria and they can contract and the blood clots can shower and they can have a stroke, they can have an MI. So a new AFib diagnosis is really important. And sometimes they can actually shock the heart back into a normal rhythm with cardioversion if it's a brand new AFib. We see a lot of chronic AFib. So you'll see there's a lot of AFib and a lot of sinus all the time. So the AFib is when we have a bunch of cells all in the atria that want to be in charge, and they're all sending out signals all at once. And the AV node is like, I'm getting too much input, too much stimulation. Well, let me just grab that one. Okay, now I'm going to grab that one. And so that's why it ends up being so irregular. And the atria are just doing this. And the problem with that is we're not getting that last little squeeze. And so it's like 15 to 20% of the amount of blood that we send out into our body. So it's a lot less cardiac output that they're getting. So the AFib patients, you know, they can be really tired and they have a high risk for blood clots and stroke and those kinds of things. Okay, so AFib is though it's very common, it's very serious problem. So if you identify that, it is an important phone call to make. A flutter, and AFib 99.9% of the time is irregular. A flutter is almost always regular, and it has those sawtooth P waves. And then SVT or PSVT is just, it's not in the atria, but it's above the ventricle. So it still has a narrow QRS, and it is regular. It is not AFib, okay? So sometimes it's hard to tell, is it AFib or is it SVT? And that's where sometimes if you can slow down the rhythm just a little bit, you can see, oh, here we have P waves, you know, regular P waves, and here we don't. Here we have, it's just kind of a squiggly line. Okay, so characteristics here. So this is, we've already pointed out a couple of AFib rhythms. And the thing that we're looking for when someone's in AFib is if they get faster. So they have the AFib with RVR. So AFib that is greater than 100, it usually gets a lot higher than that. It usually is like 120, 160, and they need medication to stop it, which could either be an IV push, usually a cardizem, diltiazem, or a calcium channel blocker. And it interrupts that those signals, and so it can slow it down. Sometimes they end up on a drip. So if you're reporting patients in AFib with RVR, or their rate is 160, you would anticipate the nurse is going to do something within 10 to 15 minutes, whether they call a rapid response or they call the doc and get the medication. You would expect the heart rate to decrease, and you would hope it doesn't continue to decrease or just decrease for a little while and then get faster again. So a patient like that, you're going to be kind of monitoring for those things. Are they doing something for the fast rate? And then what does it look like after they've done whatever they've done, which is either a medication or they can have them cough or bear down, kind of vasovagal, stimulate those vagus nerves. And then you're going to watch post-intervention, what is the heart doing now? Sometimes they convert to sinus rhythm. And so that would be an important thing to note, print, notify, hey, they've converted to sinus rhythm. And then, nope, they've converted back. Now they're in AFib again. Because these are important things the doctor's going to need to know, because there's also some surgical things they can do. An ablation, they go in and they zap those naughty cells, and so they can get the heart back on track. Okay, but the faster it goes, the less cardiac output we're going to end up with, and we're not going to oxygenate well, and the patient's not going to do well. Okay, so super important. If they say something is paroxysmal, like a PSVT, it just means it comes and goes. And then if they're chronic, meaning they've had this rhythm for more than 2 days, we're going to treat them as a chronic patient. So they're usually going to be on a drug for their rate and a drug for their as a blood thinner. Okay. The AFib doesn't generally get slower and then have a problem unless we're treating it. It's more common that it gets fast. And then here's the A flutter with the sawtooth P waves. It's usually pretty regular. Nothing is always or never, but it's pretty much usually regular. And you'll hear people saying this is a 2-to-1, a 3-to-1, a 4-to-1, whatever. They're just counting the P waves and giving it a number. So if it's a 3-to-1, that means there's 3 P waves and then a QRS. That's all that means. Okay. And a lot of times you can't see the T, like all you see are P waves and QRSs. Okay. So, like 1, 2, 3, 4, this would be a 4-to-1, 1, 2, 3, 3-to-1. So we're counting the points. Yeah, but it should match up here too, but this is not as important. Do we care that it's 3-1, 4-1, 5-1? We really don't care. It just affects the rate. So, so don't worry so much about that. It's a flutter or it's not. That's really all we care about. Now, a flutter is a little different from a fib because a fib is a bunch of different cells trying to be in charge. A flutter is one cell still in charge. They're all the same shape, but it's like hyped up on energy drinks or something, and it's going super fast and the ventricles still can't keep up. Okay, so again, you're losing some of that atrial kick, that cardiac output. So supraventricular tachycardia, see, it's hard to even see the P waves. But we know it's not ventricular because the QRS is no. So we know it's something above the ventricle. So we're not going to name it something ventricular. Okay, so here's all of your criteria. The P waves are hard to see. We're narrow. We're regular usually. And we're fast. So we're like 150s, 160s. So they are originating above the ventricles, and it's we have to intervene. We can't let them stay tachycardic because their heart will get tired out and they could end up coding. The non-RX maneuvers, non-pharmacological, that's the coughing and the bearing down. So if you're ever with someone who has palpitations or they you can feel their pulse and it's really, really fast, you can have them try those things and they might get them out of it. Okay, it's all has to do with that vagus nerve. Okay, so here's some more examples. So what do we think about that first and second one? Because they look kind of similar. They're both AFib. How is this one different? The second one, how is it different? Yeah, it's a little faster, right? And these examples are good because they don't really show like a lot of P waves. Like it's hard to even tell that there are P waves. What about this one, the third one? If you're not sure, you want to break it down into like one complex. That helps sometimes too. Yeah, it kind of looks like a flutter. I would have to see if it marches out. This looks like a patient who's either in AFib or a flutter trying to go into an AFib or an A flutter. And some patients will do that with sinus rhythm. And they'll be like AFib, and then they'll convert to sinus, and then they'll go back to AFib, and keeps things interesting. But sometimes it's a little hard to keep track of. Okay, how about this one? That one looks a little different, right? Yeah, that looks more, these all kind of look like the same shape. They're a little more of the sawtooth. That's more what a real flutter looks like. Okay, how about the next one? Yeah, that looks like a vest. So it must be regular, but it looks deceiving. It does kind of march out, but it's kind of hard to tell without like printing it out. I think that one's a little more challenging. Okay, what about this one?
That's regularly irregular.
Yeah, so it's an A flutter. It's kind of, kind of back and forth a little bit. Yeah. Okay, what about the next one? Yeah, so it's hard to see the P wave because like the T, like they run together a little bit, right? And it is regular. It's narrow. At minimum, you would tell them the rate. You'd say the patient's heart rate is 160. And then depending upon how confident you feel, you can say what you think it is. It doesn't really matter. They're going to have to go look at their patient and they're going to have to call the doc, and they probably should get a 12 lead before they call the doc. Okay. And then it matters if it's sustained or not, because sometimes a patient will do that. Maybe they got up and went to the bathroom, and when they get up and do activity, their heart rate goes up. But once they get back in the bed and they've settled down maybe for 20 minutes or something, or they're in pain because they got up and now they get their pain medicine, it might go back down and not sustain anymore. But we still need to notify the nurse because we can't see the patient. We don't know what they're doing. Sometimes they're out of bed in a puddle of poop and the nurse didn't know. I mean, it could be that too. So, okay, so what do we think about this one? Yeah, it looks irregular, right? With a wide QRS, definitely a little bit wider. So AFib with a bundle branch block because the QRSs are wide. And then another SVT. Again, we can't really tell the P wave situation, but we are narrow. Okay, then do we need a break? Are we good? We're good. Okay. Ventricular rhythms. We've got a VTAC and we've got a VFib. We've got an asystole and we've got a PEA. These ones are maybe a little more straightforward. So I think I went back. Okay, so VTAC is where the whole heart, the whole ventricle is just going super fast and we're not getting good contractions. We're not getting good oxygen to our heart. So these are bad emergent things. So if all of our ventricular waveforms look the same, then it's monomorphic. If they look different, like here, they get big and then small, then big, then we have polymorphic VTAC. So we usually call this VTAC and this torsades, okay? The reason it's important to identify torsades from regular VTAC is because we can give MAG. We know through research that MAG often helps. Even if their MAG wasn't low beforehand, we'll still give it because it might help. And it's probably not going to hurt them, okay? So it's important that we do identify torsades different from just a regular VTAC. And if we talk about that 300 method again, the wave is between these two bold lines. So it's, going at least 300. Now this kind of patient, they can have a pulse or not. I've had patients that go into this. So I go in the room to check on my patient, and on the inside, I'm like ready to code this person. And they're just sitting there watching TV and they're like, what? So it tells me we have a very short amount of time to intervene while the patient is still okay. So it's important that the nurse checks to find out, one, that they're not brushing their teeth, and two, that they have a pulse or they don't have a pulse. It's always wide because it's from the ventricles. And technically 3 PVCs is VTAC, but we're probably not going to call the doc until we have like 10 beats. But you're going to let the nurse know, hey, you've had 3 beats, 5 beats, 10 beats, however many beats of VTAC. You don't necessarily have to say mono or polymorphic unless it's clear, but VTAC is bad enough to say VTAC, okay? So it pretty much just looks like this. It's the only variation is if it's because the patient's moving somehow. This is a real patient. This is a torsades. You can see how it gets big and then small. This is what they do if their QT gets longer and longer over a couple of days. They can go into this torsades. So we're either going to, we're going to give them MEG, we're going to shock them, and then of course we're going to have to do CPR because this person is not alive anymore. Okay. But we have to shock them. And then VFib. The VFib looks several different kinds of ways. This is a coarse VFib because it's really dramatic. This is more of a fine VFib because it's kind of small and subtle, you know. We're treating them both the same way. And even if you have this with less bumps and we're thinking, oh, is it asystole? Is it VFib? We're still going to shock it just in case it's a fine VFib that we can't really see very well, either because of pad placement or just because of our human vision or, you know, whatever. We're still going to try to shock it. So asystole, super important that we make sure all the leads are on and that they're on correctly. So we're going to let and that's even worse than they're just off telly, right?
They weren't telling us.
Oh,
Like we kept calling.
yeah, yeah. And it's not dialed in for them to call very often. Hey, the patient's doing this. Hey, we're going to go here. We're going to go there. Usually you call, I did the breaks today and you call and they're like, oh yeah, sorry, they're doing this. Or yeah, sorry, they're doing that.
Sometimes you call and they're just like, I'm in here. And it's like they're irritated. It's like, well, you could call me.
Right. Right. Yeah. We're trying to figure out a way. I guess the old phones had like a push to talk, like a walkie-talkie. And so it was a little bit easier to just, hey, we're getting up to the bathroom. And then you would know. But we're trying to figure out if there's something we can do in that way. But yeah.
Then I feel with those, they wouldn't know really function.
Yeah, PEA is hard because it looks fine. And so like, why would you even call? You know?
Yeah, they call it quote blue. She's like, they have a rhythm.
Patient looks fine, yeah.
Yeah, and then they came in and they were like, no, he didn't pulse this.
Yeah. So, I mean, I probably would still print it, you know, then, and just like, I have it, you know, and then the nurse is going to document, obviously, there's no pulse and all that stuff. And then on the code sheet, they can check PEA and what rhythm it was. So with the PEA, you're going to still treat the rhythm, but you're also going to treat the patient. So you're going to do the CPR and the meds and the whole code blue thing. But if they're tachycardic, you're still going to treat and give them the drugs for that, if that's the case. Because now you're just having electrical activity that the heart's not picking up. So you're trying to get the heart to, you know, like, let's go now. Come on, we still have electricity. We still have, you know, hope. So there's a list of things, they call them the H's and T's. And it's just a way, a mnemonic for us to remember what it could be. And it's things like low oxygen and blood clot, stuff like that. So we usually run through the H's and T's and try to address them all until hopefully we find the right one. Patient's bleeding. Okay, well, maybe if we give them some blood, things will start going again, you know, those kinds of things. So here we have an asystole and then a VFib to asystole. And then just a straight PEA could be any of these things. Well, some you would call, some you would not. And sometimes the nurse will call and say, hey, what are they doing on the monitor? Because the patient doesn't look so good. And you're just looking at, you're like, it looks fine, you know? But again, important information. Okay, so what do we think about the first one? VTAC, right? Monomorphic if you're fancy. What about this one? Torsades is usually a little more squished together. Yeah, like a coarse VFib. Coarse VFib, yeah.
Yesterday was the. She was coming.
Mhm.
Ethan was super nice.
Oh, was it? Yeah. And every patient is so different. That's why some of this stuff is a little bit challenging because you're like, well, it doesn't look like the last one that I saw. So yeah, so this one, yeah, that's like a textbook. Yeah, so then this one, I know.
When I saw it, I was like, oh, something.
Wow, something I recognize. So this one looks really different from this one, but it's actually the same type of rhythm. And then of
It's
course
just so widened, right? It's just the QRS.
it's wide, right? And there's no P's. And it's like, so like if we take one on the dark line, 300, 150, it's not going quite as fast as we would expect, but it's still going pretty fast. And of all the fast rhythms that we know, really the only wide one is VTAC. So we would be going between what rates go at 150, what rhythms do that. It's
And
not
to
SVT.
count it- To count it, you count the peaks, right?
The
Like
peaks.
peaks. Okay.
And then the bottom one, of course, you already said was a VFib, of course, VFib. What about that top one over there?
Basis.
Yeah, this could be asystole or a fine VFib,
I didn't even see.
or a fine VFib. So we're probably going to shock that one either way. Either way, they have no pulse. What about this one? It looks like it's going into a torsades. And then what about this? Yeah, so this is regular. Yeah, so this, is kind of hard to tell. Is it VTAC? Is it SVT? It's, yeah, you can look at the different leads. And if you're, so like, if you think about how a 12 lead is done, it's like there's a person standing in the middle of a circle of people. They all have their cell phones. And the person in the middle does some funny dance or whatever. Everybody takes a picture. They're all taking a picture of the same thing. They're all getting something different. So when you look at different leads, you're all looking at the same thing. So if you have a PVC in one lead, you have a PVC in another lead. So if you have a VTAC, you're going to have VTAC in all the leads, not just one lead or two leads, because the heart doesn't just fibrillate in one little spot. The whole thing fibrillates or it doesn't. Okay. So yeah, so that's a good point. It also kind of looks to me like this maybe could be like a left bundle branch block, like we've changed rhythms. Either way, this is a phone call. Now, it could be something as simple as they changed the patches, 1, 2, and they put them in different places, or 2, they put them on wrong. But either way, the nurse is going to need to go check on the patient and check their leads and make sure everything is accurate. And maybe that's what their new rhythm looks like. And the nurse needs to decide, is this something I need to call on or not? Because people don't generally have those kinds of rhythm changes. Maybe it's an electrolyte issue, it's hard to say. What about this one? Yeah, definitely a torsades. What do we have here?
The bundle branch block.
Yeah. Oh. Ah. What I clicked, but that was not what I wanted to click. Okay, left bundle.
I get confused with this one and the second one. Yeah.
This one and this one.
I always.
Yeah, so the VFib is just small. Or small. The torsades is like you took this, scrunched it together, and then like twisted it. So this is like the twisting of the points, it's French. So that's why it gets narrow. right? It's wide and then it's narrow, and then it's wide and then it's narrow. That's the difference, yeah. And this is just all the way across, this is, okay?
Your torso, Taurus.
Whatever works. Yeah. Okay, what is this? Yeah, that's kind of bad, right? So if we had more than one of these, it would almost be like idioventricular, where it's like the last beats of the heart before it stops. We also call it agonal. So it's like there's a beat, there's another beat. It's the same thing when someone says they're agonal breathing. They have a breath, you wait and you think they've died. Yeah. Oh my God, there's another one. We call those agonal. Okay. Okay. What about this one?
Well, holy. The pressure. Torsades.
Yeah, definitely. Right. So it's small and then big and small and big.
20 times 4 is just but it's team.
Or polymorphic VTAC. What about this one? Yeah, monomorphic VTAC. So here, that part's pretty easy, right? That looks just like this. What are these?
It's like the heart is in and out of the tech, like it wants to function, but then it goes back
Right.
to its rhythm.
And so this is probably a P wave, right? And then kind of a wide QRS. And then it just can't hang on to it for whatever reason. Yeah. So we're still going to call it VTAC.
So would that show if like saying they're trying to help the patient out of BTAC and it's like starting to function, but then it just goes back out of it again?
It can. Now, if we were to shock them, it would be like a big artifact thing right here, and then something else. So that's how you would know.
Like that yesterday.
Mhm.
Well, when I called the nurse, it was like that too. It was just like 2 peas. She told me that she saw some peas. So
She saw some P's in here.
just like that.
This part.
Yeah. So then when I just called it, like change rhythm, heart rate is this.
Yeah.
Just not being.
I mean, the nurse can do. You can say it looks like VTAC. The nurse should get a 12 lead if the patient looks fine. The nurse goes and looks at the monitor, which is what they should do, and they think it's something else. You know, that's their responsibility to figure out what is it and what am I going to do about it. Your job is to let them know, hey, this doesn't look good or doesn't look right. It doesn't look the same way it did. And because they're not constantly looking at the monitor. So you're just like helping them out to be their eyes because they're not seeing the monitor. If an ICU nurse went to work on tele, every hour or two, they'd be in the nurse's station looking at the monitor because that's how we're trained. We're programmed that I want the monitor because it gives me vital information. They're trained that, oh yeah, they're on tele. It's kind of an afterthought, right? They're not really thinking, oh, I need to always be concerned about what they're doing on the monitor. It's just a little different mindset, right or wrong. It's just a little different mindset.
But
Okay.
we give them our point of view, and then at the end of the day, it's
Their responsibility. Yeah. If you go to court, they would just be asking you, what is your job? And what did you report in this case? And you would be looking at your chart and you'd say, well, I called here to tell them it was VTAC or whatever. And as long as another monitor tech could get up there and say the same thing, yeah, I would call because that looks like VTAC. That's fine. But the patient part and safety and all that stuff, it's all up to the RN. And they take what you tell them and they do whatever they're going to do with it based on their experience and knowledge. Okay.
That was actually the other day, there was a patient. The patient had a change in rhythm. I think it was a Saturday. I can't remember, but patient had a change in rhythm, so we called the nurse and we're like, it looks like second degree and the QRS is widened. Like it was just the patient who was and she called us back. No, it was because when I was alone, we were with her. So I think it was the day before. Because she works Sunday, I think Monday, Tuesday, Wednesday. So it might have been Wednesday of the week before. And we called the nurse and the nurse was like, okay, we'll get an EKG. And then she called us back and she was like, oh, just to let you know, it wasn't what you said. It was A flutter. The EKG said A flutter. So we scanned. I was like, well, I already scanned what we saw, so you can make that interpretation. But we're like, okay, because it was two different things.
Well, and the EKG is going to get there in 10 minutes. It could definitely change in that time. And also, they're not trained to read the EKG. So they're going to read what it says.
Yeah.
Which is not always correct.
Yeah.
So that maybe wasn't necessary, or they could have just called and said, hey, the EKG said this, thanks, whatever. But yeah, so I think that just is some training that needs to happen. Whether I had some tele nurses yesterday and they were not confident at all with their rhythms. And they said they felt better, after going over stuff. And I think they just need to switch their perspective a little bit more and kind of just have more practice. And I think it would help, So we're working on that. Okay, yeah, so then we've got an asystole. And then what do we have here if we have no pulse? PEA. What is this rhythm though, without knowing they don't have a pulse? Junctional, right? It's missing the P. So junctional is either missing the P or it's upside down.
I learned that because I didn't.
Oh, okay.
I didn't know. Karen was on that. She was like, when it's the P's upside down, it's inverted. It's junctional. No idea.
Yeah.
I just assumed junctional. There was just no P at all.
And that's usually what it is. But yeah, sometimes you do see the upside down P. Okay, and then we have another Versats, another PEA. Yeah, another VTech. Okay, so just quickly on the blocks, because we kind of already went over it and you guys seem to have a pretty good grasp of it. So the AV blocks, remember, are first, second, third degree heart blocks. So here we have the prolonged PR, and then we have the type 1, which is the wink with one eye, Winky Bach Mobitz 1. So it's longer, those kind of all at the same drop, okay? But it's always the same pattern. And then the second degree type 2 is the random dropping of complexes, but your PRs should all be the same, and they're not usually in a pattern. And then the third degree are the P's march out and the QRS's march out separately of each other. And it's usually a bradycardia, okay?
So if they first put the patient on the monitor saying and they have like a third degree or second or whatever it is, we just call them, let them know like, hey, it looks like this, even if they already know, like just to make sure they know.
Yeah, if you haven't talked to them, you don't know if they know. Okay, and things can change from the ER to the floor, or, depending upon what kind of treatment they got, things could be kicking in. It could be any, there's just no point in speculating. You want to just be safe and say, hey, just want to make sure you knew this looks like a third degree heart block. They should not be on telly. They should be in the ICU. Okay. No, you don't need to tell them all that, but definitely call them and just say, hey, I want to make sure you know that right now this is what their rhythm is. And this just gives you all of the criteria. That's just for your reference. Okay, so again, these are just, again, all the criteria, the PR is prolonged, and some examples. I'm not going to spend a lot more time on all of that. I think doing the examples, I think, helps a lot. And then this is our type 1, right? Our dropped beat, Winky Bach. And then this one has the random, and this actually has some wide QRSs. So this one, they're already having some ugliness, right? Yeah, we don't like those wide. So we have a bundle branch and we have a type 2, second degree type 2. So we've got some stuff going on there.
In type 2, do they always miss one beat or they can miss more than?
No, like here, there's 2 in a row that they've missed, but they always have the P's marching out.
Okay.
Yeah. Because the P is fine. The atria are working fine. The P sends out, the SA node sends out an impulse, and then it gets to it either gets to the AV node or just doesn't get there at all. There's something in that bundle right there by the AV node. It just can't get through. You know, it's like they've closed the freeway off ramp and you can't get off, but nobody's told the SA node, so it just keeps sending. You know, so the P's should all march out like it's just a normal day. Okay. And then this is the third degree. Sometimes it's hard because the P's are hiding in the QRSs. So you really just have to either freeze it or print it if you're not sure, and just see what marches out. Because like this looks like idioventricular. That's kind of what it looks like, just a wide, slow QRS. And then here, like, you know, you have some P's, but like there's a P in there. And sometimes you can't even see the P inside the QRS. And so sometimes it's kind of, I think it's kind of hard to find sometimes. And then here's your poem again, and some more examples. But again, the second degree type 2 and third degree are the ones that we're most concerned about. The first degree and the type 1, most likely the patient isn't going to be harmed in any, you know, near future. Like they're going to look at medication, they might take them to the cath lab, but it's not like an emergency thing. These things, the type 2 and the third degree, I mean, they can affect the patient right now. So those are ones that they definitely need to be monitored closely, more closely than tele and MIG. So they should have a cardiologist on board. All right, so here's some more examples. What do we think about that first one, other than it's not a very good tracing? Yeah, the PR is prolonged, yeah. And they're all the same. They all appear to be the same. And every QRS has a P. The second one, yeah. It's easier to see because it's a better tracing. Oh yeah, they're both, yeah. Okay, what about this one? Yeah, so these march out. And the P, like, I don't know where the P is, so I need to find 2. And then those march out. It's like I almost want a longer strip because I can't quite, because in this area, you know, you can't really see the P. And these are a little wider because the ventricles are doing their own thing, right? They're up to their own devices. And they're separate from the P, so it makes sense that they're a little wider. What about this one? So longer, this one gets longer. And then are we dropping one here? Longer, longer. It's kind of a weird pattern.
Yeah. And then for the secondary type 1, does it always go in that pattern? It has to be 3 longer and then it drops?
It usually does, but
Okay.
apparently not, because
Yeah,
this
this
one
one-
is, but it is in a pattern. Yeah. But definitely the PRs getting longer like that,
Yeah, 'cause the
I
one
would
on
leave
top
to
of
that.
it, that's why I thought that, because it was like,
Right,
the-
long, this one's longer than this
that one looks
one.
like the Misty, and then that
Mhm.
one's long and longer, so.
No, that was a fair guess. I see where you were going with that. And then, and what about this one? Oh, I don't have anything on that one.
I was like, wait,
Yeah, because these,
It's like everyone's
Right.
doing whatever they want.
and you can't see the P there, but if there was one, right? And then these march. So yeah, I think they're both 3rd degree. It's a challenge though, you know? So you kind of, rule everything out. And then maybe you get to like, well, it could be this or that. Okay, now let me think of how those two things are different, Okay, what about that one on the top over there? Looks like the PRs are getting shorter.
I want to say it's 3rd degree.
Yep, you're right. Yeah. Yeah, because the Ps aren't associated, like there's not one for each. Yeah, there's more Ps than there should be, right? Okay, what about this one?
First,
Yeah, the PRs all look the same. They're all prolonged. Good. And then what about this one? Good. Type 2. All the PRs are the same. Type 1, no, it should be type 2. These are all, oh no, they are getting longer. Look how short that one is.
oh yeah,
They are getting longer.
I went based off the book.
Yeah, I couldn't see from this angle, they all look the same. Yeah, so it is a winky bog.
oh, yeah.
Mm-hmm. Okay, what about this last one?
It's junctional rhythm.
Good. P's are upside down. This
Yeah, it's like the
actually,
3rd degree.
this actually looks like something we haven't talked about, but yeah, so the P, because this is a P too. This is also a P,
All the
right?
P's line out. which are 6 inches.
I think because the P's are upside down, we're missing that this is just a dropped beat. Because every QRS has one P.
I can see how it can be both.
Yeah.
Because it's type 1 because you missed the beat, but it's type
Mhm.
2 because all the P's.
They're all the same, right?
spot,
They're all
yeah.
the same.
So how would you interpret
I
that
think
rhythm?
this is a PAC, which we haven't talked about really, but
But there's no P before the, like, it doesn't a PAC, it's the P wave QRS, like there's no P in between.
usually yes, and it looks exactly the same as the others. But see, this looks like it comes in a little early, and it's the same shape as the other impulses. That's why I'm kind of torn, it kind of looks like an early beat. But I think if you take that out, I think that it looks like the type 2,
Yeah, you can pick.
I'm gonna skip this one. I'm just gonna kind of show you the answers in case you want to write them down, but just in the interest of time. So there's another type 2, another 3rd degree.
Everyone access to this recording.
Yes, it will be on the ICU homepage. I don't know if you know how to get there. When you're on the intranet, when you first go,
like,
it says departments ICU, and then when you get to there, it says ICU education info.
Okay.
If you click on that, it has all my workshops, and you'll just find this and the recording.
So
I'll have it up this
later.
week. Yeah. I'll have it up this week. Yeah, so just some examples that you guys can review or compare. Okay. Well, I guess I have more. Yeah, let me just get them all up there. Because you always need to be prepared in case there's time that you need to fill. So I had extra. But I think there's one on, yeah, there's a little bit more. So the junctional, I wouldn't worry so much about like accelerated junctional and all of that stuff. Junctional basically is the SA node, something's wrong with it, and it's not sending any signals, like it's just out to lunch or something. Well, the ventricles want to beat, that's their job, and but they need some direction. So there's a cell somewhere before the ventricle that's like, well, I'm a relief charge. The charge nurse is on a call. Let me see if I can jump in and send you some signals. And so it does it, but it doesn't do it very well. And that cell has a particular rate that it normally goes, and that's the rate it's going to go. And so, but basically, we already know the rules: no P or upside down P. And then the rate's just going to depend on where in the heart it's actually coming from. Okay. This is that wide idioventricular rhythm that I mentioned before. I want to find, here's another one, take a picture of it. I just want to talk a little bit about PVCs and PACs. Okay, and then that'll be, but some of this stuff, it's fancy, it's nice to know, and you sound real smart, but it's not super important, you know? Okay, so pacemakers. So we can put a wire in the atria and a wire in the ventricle. And this all depends upon what's wrong with the patient, what the cardiologist wants to do, whatever. For our purposes, it's doing the same thing that the SA node would do and the same thing that the AV node would do. So every time you get a spike, the pacemaker has sent a shock, an electrical shock. So you'll see a spike, and then you should see a P wave if it's atrial paced, and then a spike and a wide ventricular beat because it's coming from the ventricle.
So it's always going to be wide.
It should always be wide. Sometimes though, if they're just atrial paced, and so all we're doing is kickstarting the SA node, then the ventricle is actually getting the message from the SA node, it will be narrow. But if you have a spike here also for the ventricles, it should be wide. Yeah. And so then we would say it's AV paced. We have both. Or it's V paced. It's just ventricular paced because their atria does its own thing, but the ventricle doesn't listen. Okay, for whatever reason. Okay.
How do we know, like I know we're trying to go for it, but how do we know like when they're on the monitor? Like sometimes the monitor will say, like the preceptor will say, well, let's see if they're paced, and we turn
Right.
on. Like, how do you know?
So if you have an ugly rhythm like this, it could just be a bundle branch block.
But to make sure we turn.
So then you might think, well, is it a left bundle or is it paced? If you have a narrow rhythm, it's probably not paced. I mean, it could be atrial paced, but the amount of people that are just atrial paced are pretty slim. So yeah, if you have a wide QRS and the rate is okay, like at 60 and above, then check the pacer. And pace 2 usually works better than pace 1. Okay, so I had this today. I had this rhythm without the spikes, and I was like, ew. So I asked the nurse, I said, do they have a pacemaker? She says, yeah. So I turn it on, pace 2, and there's my little spikes. I don't understand why the spikes don't show unless you turn it on. I feel like just putting the patches
And
on,
nothing happens if you always have it on,
no,
right? Okay.
the monitor might get a little confused. It might show you some artifact or something, but it's not going to hurt anything.
Yeah.
But yeah, so it usually looks like a wide rhythm, and the rate is okay, because if they're pacing, the pacemaker is going to be set probably at 60 or above. Okay, and it might dip a little. It might be 59 and then 61, and all of that is just the monitor not being able to read it exactly the way it should be. So the pacing is pretty straightforward. You have a slide, I think, of the problems, but it's not important right now. But you just know that if they're pacing 100% all the way along and now all of a sudden it looks funny, I'm going to report it anyway, you know, like they were pacing fine and now they're not. Okay. And then they'll have to get the rep out to interrogate the pacemaker and see if there's something wrong with it. But it's basically, if you have a spike and no beat, then obviously that spike did nothing. Or you have a bunch of spikes and the patient still has a rhythm, that's not right either. Okay, so this is the last thing. So PVCs, premature.
She's telling us.
Premature ventricular contractions, we know they're wide because they come from the ventricle. It just got excited and came in a little early. The thing that's important about a PVC is it does not perfuse. If I had an arterial line and I could show you a blood pressure with every beat, this one would have no blood pressure. It would be like blood pressure, no blood pressure, because the PVC is not a good beat. It's just kind of, it just jumps in and doesn't really do anything. And the other problem with the PVC is that if we put a whole bunch of them together, it turns into VTAC. Okay. PVCs, you look at the shape. You know it's a PVC because it'll just jump in anywhere and it's wide. And if they all look the same, they're all coming from the same part in the ventricle. So you could call them monomorph, you know, whatever. But if the PVCs look different, like there's several different shapes within one strip, that means they have several cells in the ventricle that are causing trouble. And it makes sense that that's worse. Yeah, multifocal PVCs where they're all different shapes. Okay, so like this is the monofocal because they all look the same. Okay. Yeah, and then here's some where we've got a couplet. Here's 3 in a row. This one looks really ugly. See, we've got one here, and then this one's a different shape, but kind of same as that one.
So 3 or more pieces in a row equals VTAC?
Technically. Cardiologist is going to be like, no, it's just 3 PVCs. They're going to say, call me if it's 10 or more. Yeah. But, you know, if they keep having it.
Look like?
This is bigeminy. It's every other beat.
It kind of looks like VTAC, but that's the RMT.
It is, but it's also going at 300 beats per minute. So we would treat this like VTAC. Yeah. Nobody's going to go in the room and say, oh, they have RMT phenomenon. Do something about it. You know what I mean? They're going to be like, they're in VTAC. Do something. It's important that you know what people say because we all want to go on.
Like, what are you talking
Yeah.
about?
That's just that smarty pants monitor tech. Okay, and then a PAC is a premature atrial contraction, so it has a narrow QRS. And it always, almost always, is the same shape as all the other complexes. It just comes in early. So you could march out all of your beats and see this one just comes in early. So if you were to march out like where it should be, you know, they all march out, but these just come in early and it's the same shape, looks the same. That's like a hallmark thing about it. Looks a lot like it. So here's another example of a PAC.
But that's what I'm reading abnormal with PAC. So some PACs could have P waves.
Right, and because I think the P is just buried, so sometimes you can see it, sometimes you can't.
Okay.
The problem with the PACs is you could end up with like a tachycardia, or they could end up going into like an AFib. So if they get a bunch of PACs, it might mean that we're watching for a rhythm change. So it's important. But a PAC here and there is not a big deal. Okay. And then I think I just have these examples. I think that's going to be it. So here these PVCs look the same. PACs, they look exactly like their buddy, right? This one, the T wave is upside down, PQRST, and that's the PVC. So sometimes it can be a little challenging. But yeah, if you're thinking, oh, it's a PVC, but then it looks like the other one, it's probably a PAC. And it's considerably different as far as how bad the patient's doing. If you say the patient is having a lot of PACs, that means something really different than the patient's having a lot of PVCs, because it could lead to a lethal rhythm. And it also could be easily fixed if it's an electrolyte problem. So any nurse worth their salt, looking at an EKG and seeing a bunch of PVCs, the first thing they should ask is, what's their potassium? What's their electrolytes? Because it's easy to fix and it's very common. Okay.
There's like 2 patients second the last 3 days I was on it, they would be in and out of bigeminy.
Yeah.
And their bigeminy would last 10 minutes and then it would go away for like 2-3 hours and then go back into a 10-minute frame. Yeah.
And some of those people have just had chronic heart disease, you know, or they have atherosclerosis, they've had an MI, whatever the case may be, and that's just what they live with. But it does reduce your cardiac output, you know. This is just nursing intervention information. Any questions? Hopefully this was a good review or good, you learned something.
Yeah.
Thank you.
Yeah.
So I challenge you to take something you learned today and teach someone else. Because that's what sticks, is when you show someone else, tell someone else. Even if it's something as goofy as, hey, guess what I learned today?
Yeah.
You know?
I'll tell my husband, he's a what?
But hopefully it'll give you a little more confidence in your job. Don't feel any sort of way about how the nurses, let me stop recording.